thank you for that kind introduction. I'm going to be talking about whether we've reached the limits of lipid-lowering therapy and what's next on the horizon. Shown here are my disclosures. I'll touch upon extending LDL lowering and whether we've reached the limit in terms of benefit. We'll introduce new non-LDL lowering therapies, which may have promise for new frontiers in this area, triglyceride-rich lipoproteins in particular. We'll cover lipid reduction for total cardiovascular reduction, and with that, I mean reducing both first and subsequent events, and also encompassing peripheral artery disease in our targets for lipid-lowering therapy. And then finally, I'll close with some discussion of inclusion of women and minority groups in our clinical trials to reach all patients. Now, I think we can squarely say that these established therapies, statins, ezetimibe, and now PCSK9 inhibitors, have squarely crossed the evidence threshold to be considered bona fide therapies that reduce cardiovascular risk, and they all work through increased LDL receptor upregulation and thereby increasing LDL uptake. Now, we've come to expect a certain cardiovascular event reduction for each millimole per LDL reduction. That's shown here on the Oxford curves in blue for ezetimibe, black for statins, and then the PCSK9 trials, both the developmental trials, Odyssey and Osler, as well as the long-term trials, Fourier, Inspire, shown here. And overall, about a 23% risk reduction if you're on the curve for each millimole per liter LDL reduction. Though if you look at the benefits in the long-term trials, we have to wonder with smaller risk reductions in those trials, about 15%, whether PCSK9 inhibitors fall below the mark. There have been some post-hoc analyses to try to recalibrate for the duration of treatment, those trials lasting 2 to 3 years. And you can see when that is done, in fact, those outcome trials do fall back on the curve and confer the expected risk reduction in terms of correlation with LDL reduction. But we must ask whether there are other potential explanations, in particular, whether there's less benefit at lower levels of achieved LDL. When you get to very low levels, is there diminishing returns? Whether there is less benefit in statin-treated patients that have had chronic long-term statin therapy, and whether there's some high response variability to PCSK9 inhibitors that may account for this effect. And lastly, whether the lack of anti-inflammatory effects has some sort of influence on the total risk reduction achieved. And that's shown here if we compare the Fourier and Odyssey outcomes trials, purely LDL lowering reduction trials, to newer inflammation reduction trials, Colcott and Ladoco recently published, and examine their cumulative event curves, what you see is that for LDL reduction, there is a somewhat delayed benefit that occurs around 1 year of follow-up. But with the inflammation reduction trials, there's immediate separation of these cumulative event reduction curves, suggesting there's additional benefit that can occur with inflammation reduction on top of LDL reduction. Now, we do have newer LDL lowering therapies coming into play now, bempedoic acid, inclisiran, and ivanicumab, which I've gone through in some more detail in the longer presentation. In some cases, these have dramatic LDL lowering, 50 to 60%. And then also in some cases, in particular with bempedoic acid, a concurrent anti-inflammatory effect with lowering of C-reactive protein. So we'll be waiting for those long-term outcome studies for results there. So we can touch upon where we're going in this field. We've done a lot of investment into HDL lowering therapies and then currently into LDL lowering therapies, but there are newer targets emerging, in particular triglyceride-rich lipoproteins. And then in the future, I expect we'll see a lot of information about Lp(a) lowering. Let's look at triglycerides and recognize that when you measure triglyceride levels, we're measuring the total triglyceride mass, but we don't really have information on the triglyceride distribution among the various lipid particles. And that may be important in terms of the conferred risk for cardiovascular events in individual patients. We have emerging evidence from both genetic studies and more physiologic studies suggesting that these triglyceride-rich particles once digested, lipolyzed, do penetrate the arterial intimal wall and do get in to promote the same atherogenic process that occurs with hypercholesterolemia in the case of high LDL levels. And we've been here before in terms of classes of medications that reduce triglycerides in clinical trials. Shown here are the fibrate trials, the major fibrate trials, the niacin trials, and the EPA trial, the GELIS trial that was published a few years ago. And what you can see on the left-hand side of this slide is that while there are some modest reductions, some trials showing significant benefit, in particular HHS and VA HIT for the fibrate trials, no benefit with the niacin trials, and some benefit with the EPA trial, GELIS trial. The more dramatic observation may be that the greatest benefits are in those patients with high triglyceride levels. If you limit the analysis to those patients with hypertriglyceridemia, across the board, significant risk reductions in that subgroup. And we now have 3 cardiovascular outcome trials that have selected for hypertriglyceridemia in terms of their inclusion and use triglyceride lowering therapies, Reduce It, Strength, and Prominent, which is projected to be out in 2022. Reduce It and Strength have already reported, and these use high-dose purified omega-3 fatty acids, international trials, having about a 20% reduction in triglyceride lowering. And let's go through those very briefly. Of course, the Reduce It trial was really a blockbuster when it came out in 2019, and you can see dramatic reductions with a high dose icosapent ethyl compared to placebo, about a 25% risk reduction over the 5-year period of follow-up in this clinical trial. What was somewhat surprising is that the achieved triglyceride levels did not predict the outcome. There was less linkage. In fact, as you see here in these curves, no linkage with the achieved triglyceride levels and the risk reduction achieved. It didn't seem to matter how low the triglyceride levels got to in terms of who was likely to benefit from the therapy. And this probably should come as no surprise, because when we look back at the VA HIT and Helsinki heart studies, that was the same situation there. The achieved triglyceride levels highlighted in red here were not significantly associated with the risk benefit in those 2 trials. So while unexplained, there may be other reasons why icosapent ethyl Vascepa reduces cardiovascular risks. Another area of confusion has emerged really with results of the strength trial shown on the right-hand side, where there has been no benefit with high-dose EPA and DHA, a mixed combination of omega-3 fatty acids, and whether it's DHA that neutralizes the effect of EPA is not clear. Whether there's a contribution of the type of placebo used is not clear. But nonetheless, the risk reductions with EPA have allowed for approval in most countries around the world, and this agent is available for use for cardiovascular risk reduction. Let me briefly go to Prominent, which is a trial that I've been involved with using pemafibrate, a selective PPAR alpha agonist, a similar trial in terms of its inclusion criteria, although focusing on patients with type 2 diabetes. The TG lowering in that trial is about 40%, so twice the TG lowering achieved with Reduce It and Strength, and also some benefits on other markers. In particular, I'll bring your attention to triglyceride-rich lipoproteins, which were dramatically reduced, about a 40% reduction at the dose being used in this trial. This trial is expected to report out soon, very similar structure to the other cardiovascular event trials, and hopefully we'll have those results to see whether a PPAR alpha agonist has benefits in these patients. There are other triglyceride lowering therapies in development, and we look forward to those agents being studied in cardiovascular outcomes trials. So let's turn to total cardiovascular event reduction first. If we look at all cardiovascular events, and this is something that we probably should be doing more commonly, as shown here for Vascepa, dramatic reductions again. If you look at total cardiovascular events, over 500 events prevented when you sum up the first, second, third, and fourth event. And of course, clinically, that's what we want to do for these patients, prevent not only the first, but subsequent events. Moving forward, I think we also need to focus on peripheral artery disease. Shown on the left is the proportion of individuals living, or the number of individuals living with PAD, and you can see more individuals living with PAD than other major forms of cardiovascular disease is really an underappreciated vascular disease that we need to pay more attention to. On the right really demonstrates the gaps, that there have been over 25 cardiovascular outcome trials of anti-diabetic agents, again, a population at high risk of PAD, but less than 1/3 of those looking at PAD outcomes. And if we look, we may actually find a benefit. These are results from the field trial, which showed a benefit of that fibrate in terms of any amputation, whether they were minor amputations, probably having a more benefit, and then major amputation shown here with less of a benefit. We'll be adjudicating PAD outcomes in prominent to see if we can replicate these findings. Finally, I want to end with some data and reflections on our enrollment of women and disadvantaged minorities. Sex and race, I think we have to consider as both social and biologic constructs. There are many social determinants of cardiovascular health that come along with sex and race. Some of those are shown here on this slide. There are definitely some sex-linked biologic determinants, and certainly our underrepresentation of these two groups of patients in our cardiovascular outcomes trials does limit our global mission to achieve cardiovascular risk reduction. Now, we all know about the underrepresentation of women, but I think the problem is really amplified for minorities. And these are data that were just recently published showing that the participation of African Americans in cardiovascular drug trials that achieved FDA approval over the past 15 years or so has been really low compared to their proportion of patients that actually are afflicted with cardiovascular diseases. And that's reflected by the PPR shown on the left. Anything below the red line is underrepresentation. Anything above the green line is overrepresentation. What's shown in the orange bars are really a dramatic underrepresentation across many cardiovascular types of diseases. And then on the right-hand side, that we really have not achieved much movement in this area, and we need to focus more aggressively. If we look, there may actually be important biologic differences, and I've tried to highlight this here, data from the Dallas Heart Study. You can see on the left-hand side for Black women, on the right-hand side for Black men, those markers that seem to be higher in Blacks as compared to whites, and those that seem to be lower in the orange in Blacks as compared to white. Similar across sexes. However, some important differences that may have implications for who will benefit from emerging therapies. Lp(a) being much higher in these individuals, and triglycerides being somewhat lower, just to mention just a few. So I'll close there, and I'll hand it over to our moderators for the discussion period. Thank you very much.